Good morning, everyone. Today we are going to see about SARC. Myself, Dr. Akshay Balaji, Department of Surgery, Sri Lakshmi Narayana Institute of Medical Science. Okay, SARC. So first we can give you some objectives before going towards this class. So what it's going to be? Basically, any conditions we take care of five things: definition, types, pathophysiology behind that, its clinical features, science, management, which includes investigation and treatment. This forms our objective of our class today. So let's now first move into definition. So what do you know about SOC? Shock is a physiological state characterized by systemic reduction in tissue perfusion, resulting in decreased tissue oxygen delivery and increased oxygen demand. So this is a diagrammatic depiction of our shock, in which normal state the O2 delivery and O2 consumption is higher and O2 demand is lesser. Supply is more and demand is less. Whereas in shock condition, as you can see, supply is less but the demand is more. It's like a seesaw given between the O2 consumption and O2 delivery for your easy understanding. Types of shock. So there is basically four types: hypovolemic, cardiogenic, obstructive, and distributive. So first we'll move on to hypovolemic shock. What is hypovolemia? Loss of blood. That is known as hypovolemia, a state with which you develop shock due to the loss of blood. Hemorrhagic type trauma, such as accidents, RTA, or any war situation or anything. Gastrointestinal, uh, gastrointestinal bleed, etc. Retroperitoneal, non-hemorrhagic fluid depletion in conditions such as severe dehydration, vomiting, diarrhea, especially in children, intestinal fluid redistribution, thermal injury, burns inside a closed room, trauma, anaphylaxis. Anaphylaxis can range from various things due to hypersensitivity reactions. As you can see, the various type of hypovolemic shock in this image, where this is a first image is trauma, loss of blood. Second image depicts condition where there is thermal burns injury. And third condition, a child is suffering from severe dehydration, where there is obvious wasting of muscles and all seen. Valve cardiogenic shock. Valvular heart disease, myocardial infarction, cardiac arrhythmias, cardiomyopathy. As you can see, this is the image of a heart that has been uh, gone to a state of shock. Obstructive shock, cardiac tamponade, constructive pericarditis, pulmonary embolism, tension pneumothorax, air embolism, in which obstruction occurs. Like in case of pulmonary embolism, an emboli goes and obstructs the major blood vessels of heart and causes your increased demand and reduced supply, and which leads to shock. Same ways, cardiac tamponade, constrictive pericarditis, tension pneumothorax, air embolism. These conditions should be handled at utmost care. Neurogenic shock, paraplegia, where your upper part of the body gets paralyzed. Quadriplegia, where your head region gets paralyzed. Trauma to spinal cord, spinal anesthesia. can cause neurogenic shock sometimes. As you can see here in this image, they have shown motor cortex, spinal cord, spinal nerves, cervical 8, thoracic 12. So say with me C7, T12, L5, S5. C7, T12, L5, S5. And you can see hemiplegia, paraplegia, quadriplegia in these images clearly. Anaphylactic shock. Anaphylaxis what? So anaphylaxis generally means allergy. Allergy occurs due to a stimulant uh, which can result into severe hypersensitivity reaction and cause death within minutes. Common allergens include bees, uh, food materials, allergy to penicillin, allergy to other medication, some sting bites and shellfish bites and penicillin anesthetic drugs, etc. Now in this image, you can clearly see in first image, they have shown bee stings and the medications and some food materials that contain anaphylaxis. Now this is a second image shows clear bruising and anaphylaxis seen. Third image shows your edema of your lips and swelling, generalized swelling that occurs due to anaphylaxis, probably due to hypertension, hypersensitivity reactions. Septic shock. Septic shock occurs, as you actually know, septic, the word means itself infections. Infections can occur due to various bacterial organisms, gram positive and negative, and fungi, virus, protozoa, even them can cause septic shock. As you can see, image 1 shows clinical image of where septic shock has occurred, and image 2 shows how the septic shock occurs. Now we can see any organism, foreign organism entering into pathogenic organism entering into a body, host creates a systemic inflammatory response, which further causes diffuse endothelial disruption and microcirculation defects and global tissue hypoxia and organ dysfunction. Severe sepsis occurs, multiple organ dysfunction and refractory hypotension, which leads to septic shock condition. Now, this is a graphical depiction of infections in a small child's body. Endocrine etiology, hypo and hyperthyroidism. Severe hypo and hyperthyroidism can cause shock. Adrenal insufficiency can cause shock. Now you can see in these conditions, bulging eye, enlarged thyroid, this Addison's disease. You can see low cortisol level, hypoglycemia, hypercalcemia, high ACTH, uh, hypoaldosteronism, which can lead to shock. Now, cell switch from aerobic to anaerobic pathophysiology of shock we can go. Cell switch from aerobic to anaerobic metabolism, lactic acid production, cell function ceases and swells, membrane becomes more permeable, electrolytes and fluids seep in and out of cell, sodium potassium pump impaired, mitochondria damage, cell death. As you know, for any organ, its cell is important. For any cell, mitochondria is the powerhouse. So this is the pathophysiology of the shock. Sodium potassium pump impaired, mitochondrial damage, membrane becomes more permeable. All this starts with cell switch from anaerobic to anaerobic, lactic acid production, cell function ceases. So this is an order-wise pathophysiology of how which the shock occurs. Now, even though some of your blood gets lost in some minor accident, why don't you develop shock? Or in case of a minor anaphylaxis, why don't you develop shock? Shock and multiple organ death failure. Because our body can adapt to shock minimum level at, through some compensatory mechanisms. The sympathetic nervous system, adrenal response, hormonal, renin-angiotensin system, decrease renal perfusion, release renin-angiotensin 1, angiotensin 2, potent vasoconstriction, and release aldosterone, adrenal cortex, sodium and water retention. Sorry, in the intravascular volume. Neurohormonal response simulated by baroreceptor. Increased contractility, vasoconstriction afterload, increased preload. So these kind of compensatory mechanisms can withhold the threshold of shock in case of minor correction is needed. Sympathetic nervous system, hormonal, antidiuretic hormone. Now we can see antidiuretic hormone which controls your urine output, everything, how you can monitor. Osmoreceptors in hypothalamus stimulated. ADH released by posterior pituitary gland. Vasopressor effect to increase BP. Acts on renal tubules to retain water. Sympathetic nervous system, hormonal adrenal cortex. Now, what does this adrenal cortex do? Anterior, as you see before, posterior pituitary releases ADS, anterior pituitary releases ACTH. You can remember through this anterior pituitary ACTH. A is the first, so A will come for the first. ADH, AP, ADH released by posterior pituitary. This adrenal cortex, ACTH, stimulates adrenal cortex to release glucocorticoids. Blood sugar increases to meet increased metabolic needs. Now, after shock occurs, what are the effect on your various organs? As we discussed earlier, shock can cause multiple organ failure and defects in multiple organs. So, what does it do? First, heart, decreased cardiac output, hypotension, myocardial depression. Lungs, decreased gas exchange, tachypnea, pulmonary edema. Endocrine, ADH, increased reabsorption of water. CNS, perfusion, decreased. So drowsy, blood coagulation and abnormalities like disseminated intravascular coagulation can be seen. Renal, reduced GFR and reduced urine output. Now, urine output is very important in treatment of shock. Similarly, how amount of blood loss is important in case of a hypovolemic. GIT, mucosal ischemia, bleeding and hepatic, increased enzyme levels, amylase, lipase, etc. Stages of shock. Initials, the cell becomes leaky and switches to anaerobic metabolism. Non-progressive, compensated stage. Attempt to correct the metabolic upset of shock, as said before, through different kinds of compensatory mechanism. Progressive decompensated stage of shock. Eventually, the compensatory mechanisms will begin to fail unless or until correction is done. Refractory, final stage where organ fail and shock can no longer be reversed. So, in our objectives, we move on to our next thing, clinical features. We earlier like brush what we saw. What did we saw? Shock is an improper tissue perfusion where your O2 supply is less and your demand is more. Types includes hypovolemic, cardiac, distributive, obstructive shock. These are four major types. Along with septic shock and anaphylactic shock. And in hypovolemic shock, there is loss of blood. In septic, there is infection either due to bacteria, protozoa, viral, or in case of Anaphylactic shock, it ranges from various things, stimuli to the host, like insect bite, food materials, and bee stings bites, etc. And then we have sought obstructive cardiogenic shock, and then we have seen what are the effects on various organs and what our body tries to do through compensatory mechanisms, sympathetic nervous systems, through ADS, through ACTS, etc. So now we next move on to our next objective, clinical features. Features of shock depend on degree of loss of volume and duration of shock. Two important parameters besides clinical features. Types of shock. We can classify it as three categories: mild, moderate, and severe shock. Now, let's see the various pictures of shock. Diagnosis and evaluation of shock. Laboratory, hemoglobin, white blood cells, platelets, your WCBC will be increased, hemoglobin will be decreased, PTP, prothrombin time will be increased, electrolytes, arterial blood gases will show variation, 1 creatinine is increased, calcium, magnesium level is changed, ECC shows ST elevation and QRS complex and various other abnormality, triple bundle block, serum lactate levels will be increased. Invasive monitoring, arterial pressure catheter, central venous pressure monitoring, pulmonary artery catheter, oximetry. Now, goals of resuscitation. Overall goal, increase O2 delivery, decrease your demand. As you can see in this diagram, it is clearly shown where increase O2 content, increase cardiac output, increase blood pressure. As you can see in chart, there is decreased blood pressure, decreased cardiac output, decreased O2 content. So overall goal is to increase our oxygen delivery and decrease demand. Immediate goals in shock. Hemodynamic support is needed when mean arterial pressure greater than 60 mmHg mercury. Pulmonary arterial wedge pressure is 12 to 18 mmHg mercury. Cardiac index more than 2.2 liter minimum per minute per meter square. Maintain oxygen delivery. Hemoglobin greater than 9. Maintain your hemoglobin greater than 9. Arterial saturation greater than 92%. Supplemental oxygen and mechanical ventilation. Reversal of oxygen dysfunction. Decreasing lactate less than 2.2 per liter. Maintain urine output. Increase your urine output. Reverse encephalopathy. Improving renal liver function test. Principle of resuscitation. As you can see, ABC of forms the principle of resuscitation, airway, breathing, circulation. Airway, patent upper airway, clear your airway in case of any obstruction or anything, or in case of drowning or anything, or in case of any obstructive shock and hemorrhagic shock or anything, clear the airway. Breathing, adequate ventilation and oxygenation is required. O2 support can be given. Ventilation can be maintained through mechanical ventilation if normal ventilation is not possible. Circulation, maintain the circulation. Immediately give a IV line whenever a shock patient comes. Assess cardiac function, oxygenation, and start with fluids. Fluid therapy, as we said, immediately when a patient comes to you with start with fluid therapy. Start IV line and start fluid therapy. Most commonly used fluids, ringer lactate, normal saline, or commonly called as NS, colloids, catastats, albumin, packed red blood cells. In case of severe blood loss, amount of blood loss greater than 3 units, or lesser in sometimes. In case of other renal parameters affected, infused to physiological endpoints. Hypovolemic shock management. What now you know what is hypovolemic shock? It occurs due to loss of blood, due to various reasons, right from trauma to any abdominal bleeding, retroperitoneal bleeding, etc. Now, in case of a hypovolemic shock, first restore circulating volume with blood. Packed red blood cells is more than enough. Colloid or crystalloid transfusion. Control hemorrhage. Control the hemorrhage. They find the point of bleeding or whether it's inside or outside and try to control the hemorrhage. Vasoconstrictor to pump the heart if BP is still after volume loading is less. Identify source of blood or fluid loss. Endoscopy, colonoscopy, in case of any variceal bleed, any intra-abdominal bleed, rectal bleed, you can do endoscopy and colonoscopy and identify, and you can correct the hypovolemic shock. You can do angiography, you can find out the condition of blood vessels, and you can do CT or MRI scans. Cardiogenic shock, goal of management. Treat reversible causes such as myocardial ischemia, protect and myocardial infarction, and other risk factors. Prevent reversible causes. Improve tissue perfusion. Reducing myocardial damage during myocardial infarction. Inotropic agents, vasoactive drugs, intra-aortic balloon pump, cautious administration of fluid. Fluid must not be rushed. Fluid must be administered at a steady pace. Transplantation. These are done for increased pumping action and decreased workload of heart. Consider thrombolytics, angioplasty in specific cases. Yeah, thrombolytics and angioplasty in specific cases. Extracardiac obstructive shock, like cardiac tamponade, pericardial tamponade, pericardiocentesis can be done. Surgical drainage, sudden surgical drainage can be done if needed. Pulmonary embolism, heparin, low molecular weights can be used. Ventilation, perfusion, lung scan, BP lung ratio scan, pulmonary angiography, embolectomy surgery can be considered. Thrombolytic therapy in case of other options fail to succeed. Now, distributive shock. Distributive shock, anaphylactic shock. Anaphylaxis, as you know, it's due to allergy, it's caused due to various things. Early recognition and treat aggressively. First, you need to know what is your allergens, what the host previously suffered while giving before giving any drugs or something. Airway support, IV epinephrine, antihistamines, corticosteroids, immediate withdrawal of antigen if possible, Ludicius crystalloid administration, uh, vasopressors to maintain organ perfusion, positive inotropic reagents. Management of septic shock. As you know, septic shock is due to infection, bacterial, viral, protozoal. Initial resuscitation. For sepsis-induced hypoperfusion, at least 30 ml per kg of IV crystalloid fluid should be given within the first 3 hours. Additional fluids be guided by frequent reassessment hemodynamic status. Diagnosis, appropriate routine microbiological cultures needs to be sent to understand to find the need of which antibiotic is sensitive for which organism. We can send microbiological cultures. Antimicrobial therapy. IV antimicrobial is started as soon as possible after recognition within 1 hour of sepsis and so on. Sepsis can be seen through your complete blood count with increased WBC and lymphocytes. Empiric broad spectrum therapy to cover all pathogens. Antimicrobial treatment usually is given for a duration of 7 to 10 days. Is adequate for most of the infections without skipping any dose. Source control. Recommend that a specific anatomic diagnosis be identified or excluded as rapidly as possible in patients with sepsis or septic shock, and that any required source control intervention be implemented as soon as medically and logistically practical after the diagnosis made. See, basically, you need to find out the source through which your infection comes. Unless you find that, even if you give antibiotics, you're supposed to have tendency of reinfection. Okay, then fluid therapy. Recommended crystallites as the fluid of choice for initial resuscitation and subsequent intravascular volume replacement. Use albumin in addition to crystallites if required substantial amount of crystallites. Vasoactive agents. Recommend norepinephrine as the first choice vasopressor. Suggest adding either vasopressin up to 0.03 unit per minute or epinephrine to norepinephrine with the intent of raising MAP to target or adding vasopressin to decrease norepinephrine dosage. Use dobutamine in patients who shows evidence of persistent hypoperfusion despite adequate fluid and vasopressor. So, what do you need to take as the end point of resuscitation? Classic traditional. Sorry. Restoration of blood pressure, normalization of heart rate and urine output, appropriate mental status. Erratic mental status is seen in shock. So, appropriate mental status correction, restoration of blood pressure, normalization of heart rate and urine output. Improved global, all of the above plus normalization of serum lactate levels, which is generally high in shock, resolution of base deficit. Base deficit is calculated and resolution is found out. Goal directed approach. Your unit output should be greater than 0.5 ml per kg per hour. So consider a 50 kg male or 50 kg female. Urine output must be 25 ml per hour, more than 25 ml per hour. Okay. Central venous pressure 5 to 10 centimeter H2O, MAP 65 to 90 millimeter mercury, central venous oxygen concentration 70%. So by this we complete our objectives, mainly 5 things. What is shock? Types of shock, classification of shock, clinical features of shock, investigations, what will you do, and your treatment, starting from conservative to surgical to fluid therapy to and other modalities of treatment. Hope you take some points from this class. Thank you for this opportunity.